Right, everyone, settle in and get comfortable. Today, we are going to take a deep, comprehensive journey through protection and regulation, one of the most foundational and clinically important units in nursing. This lecture is going to be long, detailed, and very thorough. Think of it like you're sitting in class listening to a professor walk you through everything you need to know. Not just the surface-level ideas, but the why, the how, and the real clinical meaning behind every concept. We're going to cover stress, inflammation, immunity, vaccines, asepsis, infection control, infection stages, lab values, perioperative nursing, anesthesia, malignant hypothermia, postoperative complications. And throughout the lecture, I'll give you clinical examples, stories, and case scenarios to bring the content to life. Let's begin. Section 1. Stress and the physiologic response. Let's talk about stress, but not just the emotional side of it. We're talking about the massive physiological, neurological, and hormonal cascade that happens inside the body whenever a stressor appears. The body has two major stress systems. One, the sympathetic adrenal medullary system, the instant reaction. This is the fight or flight response, and it is immediate. It's like flipping a switch. So here's what actually happens. 1. The amygdala senses danger. 2. It signals the hypothalamus. 3. The hypothalamus activates the sympathetic nervous system. 4. The adrenal medulla releases epinephrine and norepinephrine, and this produces a very predictable physiological pattern. The heart rate rises because your body needs to pump blood fast. Blood pressure increases to maintain perfusion. Bronchioles dilate, pulling in more oxygen. Pupils widen to improve visual scanning for threats. Blood is redirected away from the GI tract and toward the muscles. Blood glucose shoots up, giving immediate energy. This is all about survival, and this happens within seconds. 2. The HPA axis, the long-term stress response. Now, if that stressor doesn't go away, the body activates the HPA axis. Here's the sequence. 1. The hypothalamus releases CRH, corticotropin-releasing hormone. 2. CRH signals the pituitary to release ACTH. 3. ACTH stimulates the adrenal cortex. 4. The adrenal cortex releases cortisol. Cortisol is essential, in short bursts. But when cortisol is elevated for days, weeks, or months, that's where the trouble begins. High cortisol causes increased blood glucose, suppressed immune function, poor wound healing, reduced inflammation control, changes in mood and memory, disrupted sleep cycles, accumulation of abdominal fat, increased stomach acid. This is why chronic stress is a risk factor for infections, hypertension, diabetes, anxiety disorders, depression, GI ulcers. And when cortisol has been high for too long, the body enters the exhaustion stage. Stages of stress. Let's break these down more deeply than before. Alarm stage. This is the initial shock. Adrenaline is high, blood pressure spikes, breathing accelerates. This stage is short. Resistance stage. This is where cortisol stays elevated but controlled. It's like your body is saying, I can push through this, but not forever. Vital signs may look normal on the surface, but the internal workload is enormous. Exhaustion stage. Here the body simply cannot sustain the response anymore. This is where clinical symptoms emerge. Frequent physical illness, chronic fatigue, emotional exhaustion, poor concentration, impaired immunity, increased infection risk, delayed wound healing. If you've ever heard someone say, stress made me sick, this is the physiology behind it. Case example, HPA exhaustion. Let's imagine a patient named Chloe. She works 2 jobs, sleeps 4 hours a night, and has constant financial stress. She comes in with frequent colds, high blood pressure, difficulty sleeping, stomach pain, and she reports she feels tired all the time. Her labs show elevated cortisol levels. This is exhaustion stage from prolonged HPA activation. Section 2. The inflammatory response. Now let's transition to inflammation. Without inflammation, the body would not be able to contain injury, fight infection, or begin repair. Inflammation is not the same as infection, but infection always includes inflammation. Let's break down the phases in depth. Vascular phase. This is the very first response after tissue injury. When cells are injured, they release chemical mediators like histamine, bradykinin, prostaglandins. These chemicals cause vasodilation. Blood vessels widen to increase blood flow to the area. This creates heat and redness. Increased capillary permeability. The vessels become leaky, allowing plasma to escape. This causes swelling. This swelling helps isolate the injury, keeping pathogens from spreading. Cellular phase, the white blood cell response. This is where the immune system sends reinforcements. Neutrophils arrive first. They attack and engulf pathogens. Macrophages arrive later. They clean up dead cells and debris. They also release cytokines to recruit other immune cells. Clotting factors stabilize the area. This prevents bleeding and prevents the spread of infection. This stage produces pus when there is infection, because pus is made of dead neutrophils, bacteria, and debris. Exudate and healing phase. This is where fluid accumulates and repair begins. Types of exudate: serous, clear, normal. Serosanguinous, clear with a pink tint, normal early post-op. Sanguineous, bloody. Purulent, thick, yellow-green, always a sign of infection. Repair includes fibroblasts laying down collagen, angiogenesis, re-epithelialization of tissue. If healing goes well, normal scar. If not, risk for infection, chronic wound, or dehiscence. Case example, normal versus abnormal. Let's compare 2 post-op patients. Patient 1, normal inflammation. Day 1 after an appendectomy. Incision is warm, slightly red, mildly swollen, tender. No fever. Drainage is serosanguinous. This is normal inflammatory healing. Patient 2, abnormal. Infection. Day 3 after surgery. Fever 102.4. Tachycardia. Spreading redness. Purulent drainage. Foul odor. That is infection, not normal inflammation. Section 3. Immunity, innate and adaptive, in depth. Let's take a deeper dive than before. Immunity is divided into 2 major systems. Innate immunity, the rapid, non-specific defense. Innate immunity is what you're born with. It reacts the same way to every threat. Components include skin, physical barrier, mucous membranes, trap pathogens. Cilia, move mucus out of the respiratory tract. Stomach acid, destroys pathogens. Tears and saliva contain lysozymes that break bacterial walls. Inflammation, immediate response. Fever, raises body temperature to slow pathogen replication. Natural killer cells, kill infected or cancerous cells. Innate immunity buys the body time while adaptive immunity gears up. Adaptive immunity, specific, learned, and intelligent. Adaptive immunity improves over time. It involves B cells, humoral immunity. These cells create antibodies. Antibodies neutralize toxins, destroy bacteria, and mark pathogens for destruction. T cells, cellular immunity. Helper T cells coordinate the immune response. Cytotoxic T cells directly kill infected cells. Regulatory T cells keep the response from going too far. Adaptive immunity creates memory. This is why vaccines work. Case example, adaptive memory. A child who had chickenpox at age 7 becomes exposed again at age 20. They do not get sick because memory B cells activate quickly. Active versus passive immunity. In depth. Active immunity. The body produces its own antibodies. Slow to develop but long-lasting. Examples, vaccines, recovering from an infection. Passive immunity, antibodies are given from an outside source. Immediate protection, but temporary. Examples, 4-immunoglobulin. Maternal antibodies passed through placenta. Breastfeeding, case example, passive immunity. A newborn has immunity to certain illnesses not because they were vaccinated, but because mom's antibodies cross the placenta. This protection fades after a few months. Section 4. Vaccines, types, mechanisms detailed. Vaccines expose the immune system to antigens in a safe way so it can build memory. Let's break down the types in detail. Live attenuated vaccines. These contain weakened organisms that replicate in the body without causing disease in healthy individuals. They produce strong, long-lasting immunity. Examples, MMR, varicella, rotavirus, smallpox, not safe for immunocompromised patients, pregnant individuals, people on high-dose steroids, inactivated vaccines. Organisms are killed by heat or chemicals. They cannot replicate, so they are safer, but produce a weaker immune response. Often require boosters. Examples, inactivated influenza, hepatitis A, polio, toxoid vaccines. These vaccines target toxins rather than the organism itself. Examples, tetanus, diphtheria. Subunit, conjugate vaccines, contain selected parts of the pathogen, very safe for immunocompromised individuals. Examples, HPV, hepatitis B, pneumococcal. Case example, choosing the right vaccine. A pregnant patient wants a flu shot. She can safely take the inactivated flu vaccine, but not the live nasal spray. Section 5. Asepsis, medical versus surgical. Asepsis prevents infection during care. Let's go deeper. Medical asepsis, clean technique. Goal, reduce microorganisms. Used for oral medication administration, hygiene care, feeding tubes, routine wound care. Examples include hand hygiene, clean gloves, and non-sterile equipment. Surgical asepsis, sterile technique. Goal, eliminate all microorganisms. Used for Foley catheter insertion, central lines, or procedures. Sterile dressing changes. This requires sterile gloves, sterile equipment, maintaining a sterile field. Strict adherence to sterility principles. Principles of sterility, in depth. 1. Everything must remain above waist level. Anything below the waist is considered contaminated. 2. Never turn your back on a sterile field. You must maintain direct visual contact. 3. Moisture contaminates sterility. A wet surface can transport microorganisms. 4. 1-inch border is unsterile. Use only the inner zone for sterile items. 5. If sterility is in doubt, it is contaminated. The safest rule in nursing. Case example, breaking sterility. A nurse reaches over a sterile table to grab something. Her sleeve moves over the sterile field. This is contamination. Section 6. Infection control, isolation, and precautions. Let's go deeper into preventing the spread of infection. Hand hygiene, the most important measure. Soap and water is required for C. difficile, norovirus. Hands visibly soiled, alcohol-based sanitizer is effective for general contact precautions. Most bacteria and viruses. Contact precautions, organisms spread by touch. Examples: MRSA, Vrisi difficile, requires gown, gloves, dedicated equipment, droplet precautions, large respiratory droplets. Examples: influenza, RSV, pertussis, requires surgical mask, private room preferred, airborne precautions, tiny particles that float in air. Examples: tuberculosis, measles, varicella, requires N95 mask, negative pressure room. Case example: C. diff. A patient has watery diarrhea and a positive C. diff test. The nurse must use soap and water when exiting the room. Alcohol does not kill spores. Section 7. Stages of infection, detailed clinical progression. Let's talk about the timeline of infection. 1. Incubation period. Pathogen enters the body. No symptoms yet. Pathogen replicating. Patient may still be contagious. 2. Prodromal stage. Mild, vague symptoms. Malaise, low-grade fever, fatigue. This is when the patient often says, "I think I'm coming down with something." 3. Illness stage. Severe symptoms, fever, chills, specific signs depending on the infection. During this stage, the pathogen load is highest. 4. Convalescence stage. Symptoms resolve, body repairs. Patient returns to normal energy levels. Case example: strep infection timeline. A child exposed to strep may feel fine for several days. That's incubation. Then they feel a little off. That's prodromal. Then the classic sore throat and fever hit, illness stage. Finally they recover, convalescence. Section 8. Lab values, CBC, BMP, coagulation. Let's go deeper into interpreting labs. Complete blood count, WBC count. High, infection, inflammation. Low, immunosuppression, bone marrow issues. Normal, 5,000 to 10,000. Neutrophils, first responders. High equal to bacterial infection. Low equal to neutropenia, very high infection risk. Absolute neutrophil count less than 1,000 is dangerous. Hemoglobin and hematocrit indicate oxygen carrying capacity. Platelets, low equal to bleeding risk, high equal to clotting risk. Basic metabolic panel. Sodium, low confusion, seizures. High dehydration. Potassium, low arrhythmias, muscle weakness. High cardiac arrest risk. Creatinine measures kidney function. Coagulation studies. PT-IN measures warfarin therapy. High INR equal to bleeding risk. PTT measures heparin therapy. High equal to bleeding risk. Case example: hyperkalemia. A patient with K6.1 has peaked T waves on EKG. This is an emergency. Section 9. Perioperative nursing. Before, during, after surgery. Let's take a deep dive. Preoperative phase. This is everything that happens before surgery. Informed consent. The provider explains the procedure. The nurse witnesses the signature. The nurse clarifies, but does not obtain consent. NPO status. Prevents aspiration during anesthesia. Medication review. Some medications must be held. Anticoagulants, NSAIDs. Some antihypertensives. Preoperative teaching includes deep breathing, coughing techniques, use of incentive spirometer, pain management expectations. Case example: pre-op red flags. A patient who took their anticoagulant the morning of surgery is at high risk for bleeding and may need surgery postponed. Section 10. Anesthesia types. Let's go more in depth than before. General anesthesia. Complete loss of consciousness. Requires airway management. Depresses CNS. Commonly used for major surgery. Risks: malignant hypothermia, respiratory depression, aspiration, regional anesthesia, includes spinal, epidural, and nerve blocks. Patient remains awake. A large area is numbed. Used in labor and orthopedic surgeries. Risks: hypotension, spinal headache, local anesthesia, numbs one small area. Used for minor procedures, sutures, dental work. Section 11, malignant hypothermia, life-threatening emergency. Let's expand this. Malignant hypothermia is a genetic disorder triggered by certain volatile anesthetics, succinylcholine. It causes 1. Hypermetabolic state. Muscles contract uncontrollably. 2. Rapidly rising CO. 2. This is one of the earliest signs. 3. Muscle rigidity, especially the jaw. 4. Hypothermia. Temperature can rise dramatically, often a late sign. 5. Tachycardia and arrhythmias. 6. Rhabdomyolysis. Breakdown of muscle tissue. Treatment: dantrolene immediately. 100% oxygen. Cooling measures. Stop triggering agents. Treat acidosis. If untreated, MH is fatal. Case example: MH recognition. During surgery, the anesthesiologist notices rising carbon dioxide and a rigid jaw. This is malignant hypothermia until proven otherwise. Section 12. Postoperative complications, in depth. Let's go through the major complications after surgery. 1. Respiratory complications, atelectasis, collapse of alveoli from shallow breathing. Very common within the first 24 to 48 hours. Prevention: incentive spirometer, early ambulation. Pneumonia develops from mucus stasis. Symptoms: fever, crackles, productive cough. 2. Circulatory complications, DVT, deep vein thrombosis. Blood clot forms in the leg. Risk factors: immobility, dehydration, obesity, smoking. Symptoms: calf pain, swelling, warmth, pulmonary embolism. A clot travels to the lungs. Symptoms: sudden shortness of breath, chest pain, tachycardia. This is an emergency. 3. Wound complications, dehiscence, partial separation of wound layers, evisceration, full separation, organs protrude. Treatment: cover with sterile saline-soaked gauze immediately and notify the surgeon. Case example: evisceration. A patient rolls over in bed and suddenly says, "I felt something pop." The wound opens and bowel loops appear. The nurse lays the patient flat, covers the wound with sterile saline dressings, and calls the surgeon immediately. Closing. And that concludes our full, long-form, in-depth lecture on protection and regulation. We covered stress pathways and physiology, inflammation in detail, innate and adaptive immunity, vaccine types and safety, asepsis and sterile technique, infection control, infection stages, key lab values.